Welcome to AACE Podcasts. Thanks for tuning in as we elevate clinical endocrinology by taking deep dives into trends and topics that can help us improve our patient care and global health. Find the latest episodes on aace.com/podcasts. And now, let's meet the endocrine experts who will be talking with us today.
Hello, and welcome to this AACE podcast. My name is Vin Tangprecha. I'm going to be the host of this AACE podcast focused on hypoglycemia. Before we begin, I'd like to first thank our sponsor, Xeris Pharmaceuticals, for their support for this engaging podcast. And let's begin. So we have two exciting guests today who will be talking about hypoglycemia. It's actually in one of the most recent AACE clinical practice guidelines. And so I'll have our first guest, Dr. David Lieb, introduce himself.
Thank you so much, Vin. My name is David Lieb. I am an endocrinologist at Eastern Virginia Medical School in Norfolk, Virginia, where I also serve as the program director for the Endocrine Fellowship and the vice chair for education for the Department of Medicine. And I am proud to be the Education Oversight Committee Chair for AACE.
Thank you, Dr. Lieb. And we also have Dr. Jennifer Clements. Dr. Clements?
Thank you for inviting me. I'm Jennifer Clements. I am clinical professor and director of pharmacy education with the University of South Carolina College of Pharmacy. I'm a proud member of AACE, and also my background is ambulatory care, hospital practice, and transition of care.
We're so happy that both of you are here today on this video and audio podcast. As the audience may know, I'm Vin Tangprecha. I'm the editor-in-chief of Endocrine Practice, and this guideline just got published last year in the AACE journal Endocrine Practice. And what I find that was very interesting is that this discussion about hypoglycemia is actually in the diabetes guideline. So I must admit that I missed it. And so when I went back to the diabetes guidelines, I was really amazed that there is this very, very detailed section on how to deal with hypoglycemia. And had I not known about it, I may have, not really appreciated how important this section is. So I think that's why we're having this discussion today. And so I want to start with Dr. Lieb and ask him how we could use this new clinical practice guideline. Actually, it's kind of a guideline within a guideline, how we can use this new guidance on how to deal with hypoglycemia and why it was necessary to have this new information within the AACE diabetes guidelines.
Yeah, that's a very important question, Vin. And as I was going through the 2022 guideline for the comprehensive care of diabetes, I did a Control F in preparation for our podcast today to make sure that I had missed things. And hypoglycemia is kind of littered throughout the guideline. There's a section in it that's specific to hypoglycemia and to glucagon and to the management of hypoglycemia. But I think just by how many times that word is mentioned, hypoglycemia, it really shows how important the topic is to persons living with diabetes. Hypoglycemia is common. Probably happens a couple of times a week to most people with type 1 diabetes like myself. Maybe a little bit less so in those with type 2, but it's very common, it's very costly. And we know that a significant number of people with diabetes who are on insulin or a sulfonylurea or other medicines that are associated with hypoglycemia have impaired awareness to hypoglycemia. Up to a quarter of people with type 1 and 10 to 15% of those with type 2. And so it's common and not everybody can sense it. And we have a very important emergent therapy, glucagon, but fewer than 25% of people at high risk for hypoglycemia get a prescription for glucagon, and that may come up later in our discussion, especially if you live in a rural area where you may have poor access to care. Older individuals tend not to be prescribed glucagon, probably for a variety of reasons. So there are a lot of issues. And the new guidelines are much more personalized with respect to goals for care, glycemic goals, which medicines are right for which person. And hypoglycemia is a huge part of making some of those decisions. We have new ways to detect hypoglycemia that are focused on in the guideline, namely continuous glucose monitoring. And also there are new forms of glucagon. I've had diabetes since 1989. I've been excited about all of the technological advances. I never thought that I would see something besides the red kit, that I've had sitting on the shelf for the last 30 some years. So I think it's important to talk about a lot of those updates.
Yeah, this is really an amazing set of guidelines within the diabetes guidelines that AACE has published. And for the audience member out there, Control F means search, find and search. And actually, I did that myself right before the podcast. And you're right, the word hypoglycemia appears so many times in the diabetes guidelines. So I think it's really amazing. And I'm glad to see that AACE is now focusing on something that is very common and potentially very life-threatening. And something that could have long-term consequences for people with type 1 and type 2 diabetes. I want to ask Dr. Clements, in terms of the clinical practice guidelines, I know that endocrinologists see many people with diabetes, both type 1 and type 2, but also primary care physicians and primary care providers are often faced with seeing people with diabetes in many different settings, either in pharmacy, outpatient practices, emergency rooms. How can other people besides endocrinologists use these guidelines? Please help us illustrate some of the high points of the guidelines.
Yeah, I think it's a great question. When you think about recommendations and then how can we put them into practice, because that's so important and sometimes delayed when there's evidence-based recommendations. And so I think one of the first things is really we have to educate one another. I think often with diabetes, people just tend to focus on hyperglycemia and not really think of hypoglycemia. So it's really got to be an active engagement in continuing education, other staff education about what is the research, what does the guidelines say, and what are the recommendations related to glucagon. I think from that, if we focus on primary care providers, then they can involve their other team members, because if we're all involved in shared decision-making and we're all educated on what those evidence-based recommendations are, then we know we're able to implement those recommendations into practice, but also get the person involved. And that's where the person-centered care and education, I think, would follow what has already been provided to healthcare professionals. It's going to be important to talk to individuals and people with diabetes about these recommendations, because this is a big change. If they've been using the traditional kit and their family member may have had to give it, it's a stressful and a panic situation. We now can make it easy for them, and they need to know the benefits and how practical this, new product or new products can be in terms of their lives. The last thing I would like to add is that while we can educate and we can put things into practice, we need to know what works. Like, what are the best practices to increase the number of prescriptions that are written for glucagon and to ensure that people get their prescription filled? And I think this is where we can think about maybe mini quality improvement projects with our electronic health records, even piloting that out. But we have to then monitor and say, did that work or did it not? So we have to look at trends and analyze, our data that we have at our own clinics or our own institutions. And I think too, we have to still hear from the patients and our colleagues, what challenges are we still facing? Because we know this has been a little bit of a challenge in the past. And I think even with newer products, there still can be some bumps in the road, but there can be a smooth process as well.
Sounds great. So before we talk about the new products, I wanted to take a step back a little bit and ask Dr. Lee, before we move on, because there's some people in the audience who may not understand what is hypoglycemia. So maybe, Dr. Lee, could you help define for the audience what is hypoglycemia? Like, what is the clinical definition, and how should we label it? Like, mild, are there things for mild and severe and that sort of thing? Like, what is the correct terminology?
Thanks, Vin. The current terminology is based on levels. So there's level 1, level 2, and level 3. And level 1 hypoglycemia is a blood glucose or a glucose on a continuous monitor of less than 70. And many people will have symptoms at that level, sort of the neuroglycopenic symptoms that we're used to hearing about: shakiness, sweaty, hunger, adrenergic type symptoms too. That's level 1. Level 2 is when the glucose is less than 54. And that's when you start to worry that somebody's going to progress to level 3, which is severe hypoglycemia, basically a low blood sugar that requires help from somebody else. And that may be for physical reasons. The person's not able to treat themselves, or they develop acute, altered mental status related to the low blood sugar, or they lose consciousness. So it's kind of based on those levels. I remember when I was a kid, my certified diabetes care and education specialist used sort of a fire as the as sort of a similar kind of, if your shirt's on fire, that's kind of level 1. If your chair is on fire that you're sitting in, that's level 2. Level 3 is like if the whole room is on fire. When I was a kid, that was how they described it. It certainly got my attention. I don't use that so much with my patients, but it can feel like that sometimes, certainly as the patient, or for the person who's caring for the patient or the person.
I guess that's a good analogy. You got to put the fire out before it gets out of control. And so before we move on again to the different types of treatments for hypoglycemia, I was wondering if Dr. Clements could just mention some of the medications that are more associated with hypoglycemia. You mentioned earlier that we're not prescribing medications that treat hypoglycemia, but what are the medications for diabetes that should put us on the high alert that maybe there's a fire or hypoglycemic episode that's going to occur, and they need to get other medications along with those medications?
Yeah, that's a great question. I think obviously the two biggest class that comes to mind are insulin and sulfonylureas. And we know that with clinical practice guidelines, there's been some changes because we have kind of the glycemic centric approach or the complication centric approach now, especially with type 2 diabetes, where we focus on the other benefits of newer classes that have now been around maybe for 10 to 15 years. But definitely, I think if you saw an individual on basal insulin only, basal bolus insulin, definitely pump therapy, as well as a sulfonylurea, any ones in those class, we need to have some caution there. I will say, though, we reflect on those classes the most based on how they work and the fact that you're also giving insulin. But we can't forget, too, that if we add on some of these newer drugs, it is in their label that there could be a higher risk of hypoglycemia. So, for example, if you look at a GLP-1 receptor agonist, it says if you use it with insulin or sulfonylurea, the risk of hypoglycemia increases. Well, that's really because of those drugs, but we still have to be cautious, meaning that we're probably going to back down on the insulin or the sulfonylurea, or eventually maybe discontinue the sulfonylurea.
So what I'm hearing, Dr. Clements, is if someone's on insulin or sulfonylurea, we need to be thinking about prescriptions for medications that treat hypoglycemia. Is that correct?
Yeah, I mean, I think for sure that, we need to be creative, going back to, maybe many quality improvement projects. There needs to be a way to alert providers when they're in a patient's chart, based on pulling information quickly, that, hey, this person's on insulin, or hey, this person's on a sulfonylurea, especially if there's a way to track labs that may be obtained and maybe on the lower side. There's also ways, especially maybe in the hospital, and thinking of this at discharge, a way to look at scoring. And if someone has a high maybe risk of hypoglycemia based on criteria and their score's high, that they should get a glucagon prescription prior to discharge. So I think there's various ways that we could think about it and pull that information in to calculate that score.
And we're going to now talk about the treatments for hypoglycemia. Before we do that, I want to ask Dr. Lieb now, before we talk about the pharmacologic treatments, can you just walk us through the approach with someone who has just a mild episode, or I guess like where do you draw the line between like needing pharmacologic treatment versus, I guess, I don't know if it's called conservative measures or something. Like, walk us through like what you counsel a family member that in a person who has like a hypoglycemic that's considered class 1, and then what you counsel on higher classes.
Yeah, the kind of early stage hypoglycemia, glucose less than 70, or maybe somebody sees on their CGM that they've got the arrow that's pointing straight down. They know that they're headed towards that, or their insulin pump and CGM tell them that they need to eat something. Those individuals typically will do fine so long as they can swallow, with taking some sort of readily absorbable and available glucose source, like glucose tablets, 3 or 4 glucose tablets, or about 4 ounces of juice. And those things have about 15 grams of carbohydrate. So the sort of teaching generally has been, 15 grams of carbohydrate, and then wait 15 minutes, check the glucose again. And if it's still low and you're symptomatic, treat again. It's hard to do that. Sometimes it's hard to not continue eating when your glucose is low, because it's such a strong feeling. For the person that can't swallow, or has developed altered mental status and is really unable to care for themselves, that person needs help. And that's when we think about pharmacologic therapy.
Yeah, that's great. That's really useful. So Dr. Clements, I know that in the guideline, there's this distinction between, we've been talking about mixed or mixing things and ready to use glucagon. Maybe the audience isn't really aware of what the new technology is. Like when I was a resident, we only had the bottle where you mixed. So tell us what is new.
Yeah, I mean, I think we all love this term, ready to use, because it's pretty simple and kind of describes itself, because it describes the product or that medication as already being prepared and kind of packaged in a way that it's going to be immediately accessible, does not require any mixing, and you can use right away. So there's no mixing, dilution, administration. So you're not pulling anything from a vial into a syringe before you have to give it. And when we think about it, it's made to be so simple and yet effective and faster, because I've never had to give glucagon from a traditional kit, but I can only imagine someone in a situation, a caregiver, a family member, a friend, being in panic mode and so stressed, and they may forget steps as far as that traditional kit, that now we have these products that are pre-filled syringe, an auto injector, or even a nasal spray powder. And that education too is really quick when you have those demos in practice, and you're able then just to educate again the person, the caregiver, the family member, or the friend. So that's really what ready to use glucagon products means, is that it kind of takes all those steps out.
Dr. Clements, just to follow up on that, how do you decide among all the ready-use preparations? Because it seems like for people who haven't trained with these new products, like it would be sort of guessing which one it would be best. So how do you walk through all the different products with patients?
Yeah, so I can tell you maybe like the top two things that I do. The first is I always like to give every individual all the options. And so, of course, I'm giving them these options with their caregiver, their family member, their friend in the room as well. I even let them touch the demos, and after I educate them on it, and see what seems right for them. Once I kind of know what they prefer, then I've got to start to look at coverage. And I think this is like one of the biggest barriers, is just getting the coverage of these products, because they're still very costly. So even though they may prefer something, we have to go and look at how much will they have to pay for them to get it at a pharmacy. And then, of course, I can work with other pharmacists, because they can be sometimes, even though I'm a pharmacist, more creative than me, because they do it on a daily basis, in lowering the cost for them if needed. But those are probably my top two things that I'd like to do to try to figure out which one's right for them.
Are there some automatic coverages? I mean, if you have type 1 diabetes, shouldn't it automatically be covered?
I've still run into some issues with that particular statement and trying to get it. And then also, I think when some individuals see their copay, they don't want it then. So they still have that kind of decision right at the pharmacy counter, that they may not want it if they still have a higher copay. But no, I totally think that, there may be down the road some ways that this would be almost like naloxone. Why don't we have Operation Glucagon? We have Operation Naloxone, where we can look at people and what they're taking and how much they're taking, and already get them this medication to prevent a problem. Don't you think glucagon should be the same way? And maybe that will be the trend down the road. Once we see that there's trends of actually getting people this prescription, because they can still say no at the counter, even getting a $45 copay or a $125 copay, because, they may have other things they have to pay for in their lives.
Dr. Lieb, do you have any tricks for us? Because I think I struggle with this in the clinic as well. I don't have a good grasp on which product is going to be covered, which one is preferred by most patients. So what do you do?
I ask the staff in my clinic, because they're the ones that often get the message back from the pharmacy that something requires a prior auth or hasn't been covered. So I lean on my friends. I think the other thing that you all are talking about that's so important is, giving the person options with, kind of seeing everything. I really like that. And Dr. Clements, you mentioned, sort of hands-on, people actually holding the demos. We have drawers in our office, that I don't think I'd ever opened before. And now they have demos of the different forms of glucagon, so that we can take them out while we're talking to people and show it to them. And it's not just the person that has diabetes that's at risk for hypoglycemia, it's their family. So sometimes it's really helpful if they've got a loved one or a family member or a friend that's in the room. They're the person who might potentially be giving the glucagon. So it's important for them to feel comfortable with the form too, especially if they're a child or an adolescent versus, an adult. Sometimes that kind of plays a role in the decision process too.
Mm-hmm. Dr. Lieb, I know you're a big fan of the technology and CGM. Tell us how you use some of these CGMs, perhaps to prevent hypoglycemia in patients who may be having hypoglycemia. What is your strategy?
Oh yeah. So one of the scariest things about having type 1 or type 2 diabetes, especially if you have type 2 and you're on insulin or sulfonylurea, is that risk for hypoglycemia. And so I find that using continuous glucose monitors provides so much reassurance and helps to calm people, because they can just look down or listen or feel a vibration to know that they're dropping or that something's happening, and they can stop whatever they're doing to treat themselves. I think about when I was younger, I guarantee my parents were more worried about hypoglycemia than anything else. And, I can't imagine how different their sleep would have been if they had something on their phone, because I was wearing a CGM that could let them know that my glucose was dropping. They didn't know, so the CGM, I think, has done a significant amount to help people feel more comfortable with hypoglycemia and the risk for hypoglycemia, but also to identify hypoglycemia earlier, especially in people with impaired awareness. The folks that don't feel their glucose dropping when they're 60 and don't really start feeling it until they're 40, and then you're getting into that much more dangerous situation. And the continuous monitors can help to prevent that from happening, because the alarm goes off so that they know what's going on.
Yeah, I noticed that when I'm filling out these prior authorizations, the unawareness, hypoglycemic unawareness is one of the criteria. So that's great, because I checked that box off, and I can get the CGM covered. I'm going to ask Dr. Clements. So we've been talking about treatment of hypoglycemia, and it's amazing that all these new treatments are out. How do you determine when the treatment's not working, like when you have to call 911 or something something else has to be done? Like what is the approach, what is the criteria, what do you do? Maybe I'll have both of you answer this. Dr. Clements.
Sure. Yeah. I mean, I think if we go back, since we define the levels of hypoglycemia, when someone would go through at least 2 treatments for that, maybe level 1, then it was like you need to kind of call and think about going to the emergency room. I think for me, depending on the person in front of me, I have told people before that if they got glucagon from a family member or a caregiver, they may be okay depending on what their blood glucose was. But I've had people that have had to use it repeatedly. And those are always ones then where you change your education, or now your recommendations. Like once you use one, we need to really start to think about going to the emergency room, because there's people that do get severely low. But also too, I think that if you see that person that is using glucagon frequently or having it administered to them frequently, I know I've encountered some of those, then we need to really be asking, what's not working? Is it that they don't have a CGM? We need to get them that. Have we not made the appropriate medication adjustments? Is there something else going on beyond that? Because I think we need to dive down deeper. But I think sometimes our education in what to do may vary depending on who's in front of us.
Great point. So Dr. Lieb, you're a program director. We just had the first month of fellows in July. What do you tell your fellows? This is a call we get all the time, right? Blood sugars 45 from the family members calling. They've given glucagon twice already. When is it time to go to the emergency room? What's your approach?
Hopefully they've already called 911 before they call me for advice on what to do next. But yeah, I think the sooner the better often. Obviously, if you have to give somebody glucagon, that can be a very scary experience for people. And that's probably the time that you need to start thinking about calling 911 for assistance, because you just don't know what's going to happen and how somebody's going to respond. I think the point that Dr. Clements brought up about having a second dose, I think, is really important. So when you prescribe glucagon, sometimes you can choose between a 1-pack or a 2-pack. Most people need a 2-pack. They either need it for home and work, or they need to have a couple for home or wherever they spend most of their time, because you may have to give that second dose if the first dose isn't working while you're waiting for the ambulance to come. And also, I was disturbed to find out not that long ago, not every state mandates that EMS, emergency medical services, carry glucagon on the ambulance that comes to your home. So you may think the glucagon is on its way, but it may not be. And those individuals, I imagine they have to give them dextrose in some other form, intravenously. It's incredibly important for people to realize those things. And yeah, it's hard sometimes to convince folks to get it, because it can be expensive. It's not always covered, and you've never had to use it before.
Mm-hmm.
So, it's kind of like, how are you going to convince me to spend money on something when I'm spending money on all this other stuff that you've also told me to spend money on, and I'm doing it, and I've never had a severe low blood sugar. It can be a hard sell, but having done this long enough now, there are people that I meet who have an episode. It kind of comes out of nowhere. They weren't necessarily expecting it. And their only risk is that maybe that they've had type 1 diabetes for a long time. Things happen. And when it happens, you want to have something nearby. Fortunately, these newer forms of glucagon, they've got pretty long shelf lives. They're each a little bit different. They range anywhere from 1 year to 3 years, so you need to check to be sure. But and they're stable at room temperature for extended periods of time as well. So those are some of the things that you need to think about when you're picking between the different formulations. But yeah, people need it.
Yeah,
and we need to prescribe it or be involved in teams that advocate for prescribing it.
Yeah, this is really a very important topic, and probably under discussed amongst our endocrine care teams. This has been a great conversation, and I'd like to just end with maybe a few words, final departing remarks from each of you. I mean, we could probably go on for another hour, and this is such an important topic, but I was wondering what is your number one take-home message from this podcast today? So maybe I'll start with Dr. Clements.
Well, I think I would have so many, it's hard to narrow down to one. But I just hope that people take away that glucagon is very important when you think about diabetes management, and you need to start putting the recommendations into practice and evaluating the person in front of you to know if they're a candidate for it or not.
And Dr. Lieb, what is your take-home message?
I would add it, and part of this was in preparation for the podcast and for talking to you all. The multidisciplinary aspect of this is incredibly important, because if I tell somebody that they need glucagon, they may say, okay, whatever, thanks, Dr. Lee, you tell me a lot of things. If our certified diabetes care and education specialist tells them they need it, they may say, he was telling me I needed it too. I didn't really want to. And then they see, PharmD that's involved in their care, or one of the nurses, or somebody that's involved in the clinic and bringing people to the room. The more people that talk about it, the more I think it hits home, and it reaches the individual how important it is for them to have. And so I think having a true endocrine care team approach to raising awareness of hypoglycemia and glucagon as therapy, emergent therapy for it is incredibly important. And Jennifer, you mentioned, quality improvement, and Vin, you mentioned that I'm a program director. So I think I'm in a good situation to have our wonderful fellows potentially do a QI project here. And I recommend that everybody ask their fellows to be involved in a QI project to determine how often you're prescribing glucagon and where the barriers are to prescribing it and filling those prescriptions.
That would be a great QI project. I mean, it's a very important topic, and I can see a lot of areas. I mean, you could follow the metrics, and you could probably get the prescription rates to go up. So thank you again for participating. I want to tell the audience, please check out the guidelines. They're available at AACE.com, or you can go to endocrinepractice.org. Look for the American Association of Clinical Endocrinology Clinical Practice Guideline, Developing a Diabetes Comprehensive Care Plan 2022 update. You'll find an amazing section on hypoglycemia. You wouldn't know it from the title, but it's great to see that there's a lot of good information there, tables, information on treatment of hypoglycemia, and I think definitely something you should print out and post up in your office and use. So thank you very much again for joining our podcast, and thank you to the audience for listening.
Thanks for listening to another great ACE podcast. Join us for another episode at aace.com/podcasts and help us in our mission to elevate clinical endocrinology. Together, we are ACE.